It's a real pleasure to be here. I lived here for over 9 years. Both my kids were born in Ames, so it's always a pleasure to come back here. I hope I'll convince you that even though I live on the wrong side of the state, maybe I'm still on the right side of these discussions, but, you know, please, this is all about communication. So as I'm communicating to you my thoughts, you can feel free to call me on it and tell me that I've shifted to the ivory tower and I've lost my ability to talk about these things and I should just be pulled off the stage. Which I will, you know, there should be a discussion and I will gladly let anybody else up here who wants to be up here. So, as Rick said, I'm going to be taking us on a bit of a journey. And one of the things, so previous speakers have been saying things about their families and how it brings them to their communication place. So I'll give you a quick vignette of how my family brought me to this place. So my mother was the deputy director of the National Science Foundation. She was a statistician by training, really sharp cookie, not the best communicator in our family. I learned most of my communication skills from my Presbyterian minister father, which means that I'm going to show you guys a bunch of data, but I'm going to do it by telling 3 different stories nested in antimicrobial resistance. And hopefully, by the end of this, you'll be seeing the things that I'm seeing from where I sit between the 2 worlds of health, or across the world of health, shall we say, because that's really what we want it to be. So my whole purpose is to talk about One Health. Thank you to the CDC for your wonderful infographics. I'm using one of them. But I really like this one, and I think it's very valuable for the ideas that we have for this whole conference. So One Health is for people who protect animal, human, and environmental health, and all the partners that go in that. But you have to do that through coordinating and communicating. And, you know, it's not a coincidence that I'm up here talking to you and the theme is communication. But this can be directly downloaded from the CDC. Please feel free to do so. So I think when I moved to the University of Iowa 7 years almost ago, I really felt that the antimicrobial space was one that is critical for One Health, a real area that there should be a lot more happening in One Health. And I think we're moving that way. I will say that again, but that's the way I'm going to start the discussion and end the discussion. So we had a wonderful panel that told us of many of the efforts that are happening across the CDC, the FDA, and the USDA to do this. We have multiple programs that are trying to do stewardship efforts to measure where we're using antibiotics, how we're using antibiotics, where we're getting resistance, and where it's being found in animals and in food products. And all of that is nicely coming together in the National Antimicrobial Resistance Monitoring System, which it's true. They've got really cool data, and if you're a data nerd, you really should be on that website downloading the data and using it for things. But I'm going to show you one example here, my first story, to talk about that. So this is a schema that I actually put together, but it's much like the one for the last risk plan on antimicrobial resistance that kind of moved across the different worlds. But this one's focused on the opposing poles, shall we say, of community-acquired Clostridium difficile infection and hospital-acquired infection. And that's a space that I've had the dubious pleasure of working within, because what veterinarian doesn't like projectile diarrhea? But yeah, it is a little unfortunate that I'm speaking before dinner, so I'm going to apologize to you all right now. And I think as a animal agriculture focused group, the area within the square is the area that we spend the most time thinking about when we think about antimicrobial resistance. And that's where you have a pathogen, and for C. diff, it happens to be a pathogen that really does very well in the environment. It forms a spore and can live there for very long times. And what that means is that we have it in the environment, and animals can become infected with it. Those human animals can become infected with it. And basically, the way this is parsed on the human health side is literally the number of days it's been since admission when they start showing signs. So if it's 3 days or less and they're in the hospital, they're going to blame it on the community. And if it's 4 days or more, they're going to blame it on the hospital. Now, of course, we don't have the samples to prove that. That's literally a timing thing. And we know that biology, microbiomes, many other things will make this different. But I'm just telling you, that's the definition, and that's how it's parsed. But the side that I'm going to spend a little bit more time talking about and making you think about, which isn't the world you necessarily spend lots of time in, is this side. So what's happening that 4 days plus? Who are the patients that are in a hospital for more than 4 days? Why are they more likely to get infections? And what can we do about that? And what are the important communication tools that will really help us on both sides? And the first theme I'm going to give you, and then probably give you again, is life is messy. And all of us who live are messy. And there's our bodies, but then there's our microbiomes and all of the things that live with us. And we can't live without them. But I think very few people, perhaps microbiologists aside, think about that. But I think that's a key communication that we have to make. We don't live in sterile bubbles. And we have to get better explaining on why we have the bacteria we like to have with us and the ones we don't. So, this is starting the first story, and it's going to be about Salmonella Newport. And I'm going to show you some lovely NARMS data. And this one got a lot of press, so probably you've already seen the story, but if you haven't, join me on the voyage. So, prior to 2017, the rate of azithromycin resistance in Salmonella isolates was less than 0.5%. But during June 2018 to March 2019, we had 255 cases of Salmonella that had decreased susceptibility to azithromycin. So I don't need to take you guys back to veterinary school and epidemiology. That's an outbreak. That's an epidemic. That's way higher than the rate it should be. It's in 32 states, 29 human patients. This is, again, like medically important. So when it describes patients, we're talking about people. Were hospitalized. 6 of them went to the ICU, 4 of them had bacteremia, and 2 of them died. So this was a very impactful outbreak that happened. And they did the write-up in MMWR, so therefore the outbreak's over, right? That's the way this works. No, we're probably still getting cases from this, and you'll hear why as I talk about it a little more. So the cases, for the most part, were related to unpasteurized soft cheese, queso fresco, and beef obtained in the U.S., also Mexico, within 7 days of disease onset. So that's, again, how they defined a case, within 7 days. And then they used core genome multilocus sequence typing, or CG-MLST. And MLST, if you guys, I know we're not supposed to ever use lingo, and that's why I have spelled it out for you, but MLST is one of those that you are going to hear more and more, because this is the way outbreaks and bacterial isolates are being defined by the CDC and by public health. It has happened. We're there. So we're not doing pulse field gel electrophoresis any longer. We're doing this. So here is our fabulous outbreak map of our cases. And what you'll see is that within days of each other, we had a steer cecal sample at slaughter from a Texas processing plant, and then a soft cheese sample from Tijuana, Mexico. And everything on this map is within 2 alleles. So very, very, very sequenced genetically similar. There were some other ones that were a little further out. They're not being counted in this outbreak. And then several times where it says beef, I can point to one side and then the other, maybe. Beef, beef. There's my label for you. Beef. These were also from a Texas processing plant. And then you can see we have our non-human sources. These are the 1, 2, 3, 4 I just pointed out to you. And then the rest are human samples. So if you look through the fabulous data table, as all epidemiologists like to, you'll see that we have a lot more, this is NARMS data, a lot more human data than we have animal data. And this is one of the first things I'd like to say is, come on guys, we like data. Where's my veterinary data? We should be reporting. We should be getting this stuff in. And we need to figure out ways to do that better. But we still have plenty of evidence showing that these are related. So why did we have so many cases in this outbreak? And this is where I'm going to make you guys not fall asleep at 3:30 in the afternoon. Somebody shouted out, why do you think we have so many cases? I told you what the exposure was found to be. I told you what the human cases were related to going to Mexico or eating these things. And then we had several animal samples. So why is this not simple? What didn't I tell you that we usually hear in a foodborne outbreak that makes it have a lot more cases? Oh. All right, I'll give you some hints. I know it's been a long day. Too bad to travel. Okay. So we have resistance. I told you, like, the big important thing was it's resistant to antibiotics, right? It's resistant to the two antibiotics that are the to-go antibiotics for human cases. So they were trying to treat with the stuff that should work, and it didn't. More cases, right? Yeah. I'm going to start walking around the room and poking you guys if I don't start getting more interaction, I promise. This is a more recent outbreak strain. It was first detected in not until 2016, so it's not something we've known about. My microbiology professor definitely told me nothing about Salmonella Newport. I didn't know about it. So that makes it a little more harder. Prior to that, we had smaller multi-state clusters, but they weren't exactly the same, so we've shifted a little bit. But this is the big one that I was hoping somebody would come up with. We don't have a point source. We don't have one company that we could go say, hey, you're making lots of people sick. Would you please pull that off the market? This is multi-source. It's in beef and it's in queso fresco. And who doesn't like queso fresco? I mean, we're going to eat this stuff. So that's a real challenge. And we couldn't then have good messaging, right? Because that, when it comes down to it, is the theme of the meeting, but it's also the theme of good public health, is we have to be able to tell people what to stop doing. And here the message is, stop eating ground beef and stop eating fresh cheese. How's that going to go over as a public health message? Not very well. So we are probably still having cases, and that's why. So it's believed, and this is, all right, so that's the human health stuff that we have to try to address. This is the veterinary side, and you can throw things at me about this statement, because I'm not sure I agree with it. I looked up the data, but this is what the CDC put in MMWR, the CDC. So we can talk about how much we think that this is the cause, but they think that the strain, both in Mexico and in the United States, is tied to macrolide use, and that this is a major antibiotic used in food animals. I pulled the report of antibiotic use for 2017 because the 2018 one isn't out yet, and it is the third most common antibiotic used in beef, but it's 4%. So tetracyclines rule this, then penicillins, and then macrolides. I'm pretty sure we don't have data to back this up. We just know that the antibiogram is probably going to overlap, and it's suggestive. Nobody's booing, so yeah. Right. Do we have any rights to tell Mexico that they need to let us sample their stuff to figure out what the outbreak's happening? The answer is no. Not really, no. I mean, there are investigators, there are people that are doing research, but there's not a good website, Spanish or not, where you can go look this up for sure. Yes. Yeah.
Were the cattle in this Mexican origin cattle?
So it was both U.S. origin and Mexican origin. Yeah. Well, and we know that they come across the border and they get slaughtered, and I'm not getting into the mess of tracking cows and how well we're doing that, but maybe it's a thing. So here's the other one, which is a wonderful blessing, and I just told you this is where we're going, but we're using sequencing to find what's related with these outbreaks. That's compared to doing pulse field gel electrophoresis, where you had to culture something, so it had to be culturable. You had to have enough there to be culturable, and then it had to form a nice banding pattern, and then you compare banding patterns. This is sequences. We are changing our level of detection. We are changing what we are going to be detecting. We are in a different world of what we're going to be finding. It means that we're going to find things connected that we would have never seen before, which is wonderful, but perhaps terrifying all at the same time, because we need to understand what that means, right? We're in a new age of information. We're getting more. Is it all good? You'll find that maybe through my talk I'm going to pose more questions to make you think about and communicate about than I'm going to answer. But I'm around for the next 24 hours, so you can make me answer questions if you want. So here is the MMWR report. This is up on the CDC website. You can read it. I did quote from a lot of it. It's a wonderful report. It's a really neat outbreak investigation that tied these things together very nicely. But because of human behavior, because we eat what we like, because we don't always follow the rules that they taught us in 8th grade about how we should cook things, we as humans don't always do a great job in protecting ourselves from organisms that might be antibiotic resistant. Is that the producer's fault? Is that our fault? Do we like accepting fault? How do we talk about that and make people understand this better? So here's how the CDC is doing it. Stay safe from salmonella infection. Salmonella causes foodborne illness. And it just tells you where the links were. New concerning antibiotic resistance. So we obviously need to have antibiotics. We need to use antibiotics for veterinary and human things. And sometimes they won't work. So this is kind of telling truth to the people who are, going to the doctor and saying, hey, I want antibiotics for my cold. So the message, the public health message is cook your beef, which, yes, of course we need to cook our beef. I was just at a conference with a bunch of French. Usually telling them to cook their beef is a little more challenging, but choose your audiences. And then avoid soft cheese made with raw milk. These are messages much like make sure to exercise for 30 minutes a day, don't eat more than 1 serving of sugar, that make a lot of sense. We know it's good for us, but we don't always do. And that's what we need to figure out how to convince people to do better. So that's story 1. Lovely use of NARMS data. So what is the main approach to detecting AMR-based disease in people? So we've got a wide system for the Center of Disease Control called the Emerging Infections Program. Here they're defining emerging infections based on the mandate of how this program was set up in 1994, which is really focused on bacterial pathogens, often hospital-based, and then following that forward, and they're starting to address antimicrobial resistance more and more. But this network was set up for that more than other things. So, I'm a director of emerging pathogens, and I study crazy viruses and parasites and other things too, and that's not really what they're talking about. So we have a wonderful public health infrastructure across this country. I don't know if you realize that, but travel to some other places, especially ones that have been having ethnic strife and war, and you'll start really appreciating the public health that we have in this country. And because of that, and because of the system that goes from city or local, county, state, and then up to the CDC to report diseases and detect outbreaks, those are the people who are out figuring this out. And then we do have targeted grants. These are the epi and lab capacity grants in a lot of cases to look at the pathogens that are covered through FoodNet and the National Antimicrobial Resistance Monitoring System to increase our surveillance and detection. And the next story I'm going to tell is about the first time, several years ago, that Iowa's ELC group used sequencing to look at salmonella outbreak. And then we also, separate from all of the public health side and the federal side, every hospital has a surveillance network because they are judged on people not leaving that hospital infected and not having central line infections and not having genitourinary tract infections and not having surgical site infections because it's really bad for business. So they now have a director of quality, and one of the main jobs is to track and prevent antimicrobial resistance and bacterial infections at these sites overall. And then the VA system has their own network to do these sorts of surveillance systems. You'll see I credit them at the end. I did pull, so I'm telling you the salmonella story because the Iowa State Hygienic Lab actually is joint appointed at the University of Iowa. So I co-teach my infectious disease epidemiology class with the director of the State Hygienic Lab, which is really fun. I hear lots of crazy stories, and I never want to eat out in Iowa City. But and then the VA in Iowa City is right across the street, so I work closely with the Center for Access and Delivery and Research and Evaluation. They do a lot of work across the VA system on antimicrobial resistance and hospital-acquired infections. And then some of the stewardship slides I'm going to be showing you are from the University of Iowa Hospitals and Clinics and the School of Pharmacy, telling you how they're telling doctors not to be dumb when they're prescribing. And we can talk about whether or not we think these can work in veterinary-related systems. So, the EIP program. Does this alone work? Okay, I think both mics were picking me up. So, this is the map. It tends to be 2 states for every region. You'll notice that there's a region that only has 1 state. I think we should vote up another state to be a partner with it, but that's my opinion. And it is fairly focused on, like I said, large hospitals and the populations in those urban centers. So this is the EIP Active Bacterial Core that does surveillance. So they're doing active... I should just make you guys take Epi1 with me quickly and tell me what's the difference between active and passive surveillance, but I will let you escape that. So active surveillance means that they are actually going out and acquiring information about these infections instead of waiting for people to report them in. Got it? Yeah? Okay, good. So we're doing this in these sites. As you notice, some states don't have the whole state colored, and that means that they're really just doing it, like I said. So for instance, California, that dot is placed strategically. They're doing it in the San Francisco Bay Area. In Colorado, that's Denver. In Tennessee, I think that's Knoxville, because it's not over on the edge. And then in New York, it's kind of the Albany region. But otherwise, it's whole state data. And this then allows us to know what baseline is. Because in order to know what an epidemic is, you got to know what baseline is. With me? Yeah, good. I would say this is something we should think about on the veterinary side. Do we know what baseline is for animals? No, we don't. Not really. I mean, we do have academic centers that are going out and doing some active surveillance. So we have, it would be, the United States is a Dalmatian. We'd have very little dots across the country. So something to think about. So here's a piece of data on MRSA. And what it shows is that, thankfully hospitals are doing really concerted efforts on hand hygiene, on surgical sites, and we are dropping bloodstream infections. Particularly, the US 300 has really dropped, but the US 100 is dropping as well. So we're making a difference. So there's also FoodNet. So that was just basic surveillance. FoodNet is focused on 8 common foodborne pathogens. You all can read, so I'm not going to read them to you. And this is where we are doing active surveillance across the EIP network, but also through USDA, FSIS, and the FDA. This is a lot of what's in NARMS. But this also gives surveys out to laboratories and to physicians and to general population, and does population-based studies. So it's a fascinating amount of data, and I think with sequencing we're going to learn a lot, but we're also going to have to figure out what we're getting. And we had our preliminary 2018 report out in MMWR back in April, and what we're finding with these trends is, it's of course going to change because we have changed how we're looking at it, right? So you can look at this data and think of it multiple ways. You can look at the black, which is culture only, and say, oh, great, for Campylobacter and Salmonella and many of these things, it's going down. But if you start thinking about where we're doing sequencing, so the MLST, and we're not culturing anymore, that's when we start getting into these various shades of blue, and we're finding more, which I told you is going to happen. You start looking in other ways, you're going to start finding it more. So for a while, because we have now shifted our surveillance system, we are going to not know if we're doing better because we can't compare apples to oranges. So this is one of the complexities of what's going on. Are we doing better in human medicine? And what we're seeing for pathogens and then antimicrobial resistance, we don't know because we don't know how to count it. So then how do you talk about that? Hey, we got smarter in the way we're looking at it. Great! But it means everything went up. Boo. So I think, we've got to go with the good news. We have a much better idea of what's going on. And then try to get those trends going down now that we have data. So, as several people did, please jump in if I say something really dumb or provocative or however you want to categorize it. But otherwise, because all of us want to actually go and have dinner, I'm going to keep rolling. So this is the ELC, so within the CDC system, the epi and lab capacity granting. Iowa got one for Salmonella, and here's their first success story, using sequencing for an outbreak. And like I said, I apologize to any of you who would have chosen to eat this food for dinner. So what they found is that we have a very specific whole genome MLST allele that we're finding in both clinical, so patient samples. I won't fill in the blank of what that patient sample is, and food processing samples. And what this means is they went to where the food is actually processed and did swabs of that environment of the actual food and looked at what the sequence was of those Salmonella. And what you'll see is that these 17 clinical samples and both food processing samples, which have the dots by them, the big black dots, are, again, within 2 alleles of each other. So that means they are the same thing. We also had a couple of samples down at the bottom that claded off, which means that there were other things that they could find in other places that were not related. It was a different source. So obviously we had an outbreak. It's tying the food source to the human samples. And this was the first time that it really worked very well so that they quickly could identify what the source was and get it off the market. So they worked with the Bureau for Food and Consumer Safety and the Iowa Department of Inspections and Appeals. So how did they do this? Well, it's chicken salad. And we had our public health infrastructure, our EPIs, go out and ask everybody who was getting sick what they had eaten, ask people who were with them that didn't get sick what they ate, did the comparison. We were worried about chicken salad. We got samples of the chicken salad. We then put it in for sequencing. Here, they actually took all of the separate components, so they're pouring the oil that they put into the chicken salad into our nice little extractor, and found out it was the whole chicken salad. Here is the report that went out as a press release to help people know, hey, the chicken salad from Fairway is bad right now. Please don't eat it. And here's the timeline. So Fairway sells chicken salad produced by a certain group in all of its Iowa, Illinois, Minnesota, Nebraska, and South Dakota stores. The Iowa State Hygienic Lab was starting to see more salmonella that looked really similar coming in as samples. They started sequencing it. They reported it to USDA FSIS that we think we're seeing an outbreak of salmonella. And very quickly, they had it sequenced and knew that it was from the chicken salad. So Fairway elected to pull the chicken salad off of the shelves. That's why I can tell you it was Fairway, because Fairway decided to do it. So I'm allowed to talk about them. Yay, Fairway. Thank you for doing that. And then we were able to get down to the sequence level and see this happening everywhere. We could get the word out. We, the State Hygienic Lab, and the FDA, and the CDC, and everybody else that became involved in this. And this is what then happens, is it goes out in the Des Moines Register, it goes out in the BARF blog, something that I read on a regular basis. Cedar Rapids put out their report, Quad Cities, Muscatine, and then it went out to the partners in states around, and people stopped getting sick. So compare this back to our queso fresco and beef, where we don't have a point source, and the cases are still happening. Here, we had a spike, and we had a drop, because we had an intervention that clearly delineates what we need to do about this. Again, it wasn't human behavior that was the problem here. Chicken salad, well, judgment. Some people say anybody that likes eating things with mayonnaise has a problem and they should address that. You know, that's a judgment. But it should have been fine. They didn't cook it wrong. They ate it the way it was supposed to, and yet they got sick. So the public health message was basically, don't eat this chicken salad. And it worked. And it actually hit national news. So I think this is a win, right? It's straightforward. The interaction between local, county, and state public health worked very well. The State Hygienic Lab did their job. They isolated it. We could figure out what it was. They reported it back to the CDC. They worked with the FDA and USDA to make the request to recall the product. And they used sequencing as a tool that really helped us know that the tie was Fairway chicken salad, people getting sick. So I think these new tools can be very useful. But like I said, depending on the setting and whether or not we have a point source, it's going to be a blessing and a curse. And that's kind of the bottom point. So that's story 2. I feel like I'm not going to make that comparison. So I already put these points up, but here I've now got a little map of how our different hospitals and nursing homes and long-term care facilities, long-term care facilities and nursing homes are supposed to interact with public health. And within the hospital, they're also having, like I said, their own surveillance structures. So the next story I'm going to tell you is about that. And again, I think this is something where we can take it as a best practice, lesson learned, see what we can do with it. And as a hint, so I came to Iowa City thinking antimicrobial resistance is really one of these things where we should have lots of people to interact with and great take-home messages. We've got the VA right here. We've got the big teaching hospital right here. We've got the State Hygienic Lab just down the road. How often does UAHC report its cases to the State Hygienic Lab? Almost never. They're down the road from each other. The Hygienic Lab literally has appointments at the hospital, like with the university. They are in the same institution, and they're not reporting. So, sometimes it sounds great, but it doesn't work as well as we want it to. And that's the other thing to remember. Because there are other pressures, other powers, the problems of doing the paperwork, lots of other problems that make it so that the things that you think are straightforward are not. They don't always work together. And then there's the VA, and the VA is another world, basically. So comparing UIHC to VA data is very challenging. So here's, again, some of you will know this and be like, yeah, Petersen, please, you're teaching me things I already know. But some of you who haven't had microbiology for 20 years, like me, might think this is interesting. So the way in hospitals that they are identifying bacterial contamination or bacterial presence, pathogen presence, let's say, is through MALDI-TOF mass spectrometry. So they're not often culturing anything anymore. This means that they get data within the day, and they can make clinical decisions based on isolating something in the same day. But it means that you find everything, and you don't always know whether that microbe that's present is what's causing the disease. And again, it's a challenge. We're in the world of data. We can get a ton of it. You have to decide what to do with it. But it's pretty cool. Basically, from a urine sample, a blood culture sample, a CSF, or an actual bacterial culture, you can directly go to MALDI-TOF and find out what you have and make decisions and use an appropriate antibiotic, which is very important for stewardship. And then, you can wait for it to be cultured to find out what the resistance or susceptibility is. But at least you can make that first decision knowing what pathogens are present. So this fantastic woman, Geneva Wilson, did a randomized control trial using MALDI-TOF to identify the pathogens that are present on the lovely privacy curtains in hospitals. We already had one laugh, but so privacy curtains are a great idea. Privacy curtains mainly are because in wards you want to be able to see your patients, but occasionally the patients have to go to the bathroom or change their clothes or do other things that they want privacy for. So they move the curtain so that they can have some privacy and not have the nurses looking at them through, often glass sliding doors. Privacy curtains are changed quarterly. Yeah, unless visibly soiled. And in order for a doctor to see a patient, they clean their hands as they enter the room. They move the curtain, fine, their hands are clean. They do what they need to with the patient, they move the curtain again. And then they go wash their hands again. So that curtain is touched by everybody who has to touch the patient before they can do anything about moving the curtain or cleaning their hands. Because of a series of events, my husband had to be hospitalized in August, and the first thing and the only thing I could get through my brain was, don't touch the curtains! But this is my problem, not yours. So, what we did, and what Geneva did, really, I just got to give her ideas, was they hung fresh curtains. And some of them had a neat antimicrobial product in it that is supposed to decrease bacteria that can colonize on these curtains. And from, I think it was 100 centimeters down to 20 centimeters, we would take multiple cultures down the panel. At set amounts, they had little dots on it so you couldn't mess up. And we did both for Clostridium difficile and then just good old blood agar and saw what we grew. And then we processed them through MALDI-TOF. And I'm not going to show you all the data, but it was terrifying how much grew on these curtains and how quickly. This is a time to event curve. The top one is how quickly they became colonized with at least one pathogen. So this isn't one bacteria. This is something that is published in the literature to cause really bad disease. And it happened within 3 days. In some, you'll find that the standard curtains, which are the big black dots, did kind of lead the trend, but unfortunately, for the company who was trying to make the BioSmart curtains, it didn't make that much of a difference. Spraying with bleach did for somewhere between 15 minutes and 2 days. And then it caught right back up. So I'm not giving you this story to terrify you about the curtains like the world I live in. I'm telling you this story because we are able to do randomized control trials in the hospital to try to figure out things to intervene with the messy world that we know our patients are in the surgical ICU, in the other ICUs, because sick people are not clean. So this just gives you what the curtains had. As you'll see, there was not a big difference between our supposedly better, less colonized. And then the post-spray was literally, we sprayed bleach on it. It cleaned it off, and then it came back. And this is in review, so hopefully it will soon be published, and you guys can look up all the fun, crazy data for it. But here's the big picture that I want you to think about. Places where sick people live are not sterile environments. There's lots of microbes there, and some of them are pathogens, because we're bringing sick people together, and they have them. And it's very hard to keep that environment clean. The things that we have to do that are things like good hand hygiene, are things like scrubbing those surgical sites, are things to make sure that we are trying to keep the people as healthy as possible. And thank goodness most of us have good immune responses and we can keep ourselves healthy. But for the sickest, this is a real challenge. And it's not one that we are making strides, but it's not anything we're ever going to win, because the pathogens are smart and they adapt, and we have to keep fighting the battle. So the person Rick, who introduced me, who put me up to give this talk, he said, "So are we doing better in human medicine?" We're making strides, but I don't think it's something that we're ever going to win. It's just something that we keep fighting for the rest of our lives, because that's the way this works. And I think it's the same on the animal side. So the thing to remember, and the thing I'd like you to think about, because this becomes a blame game, and what we often hear from the human health side is that, we might be infecting our patients in the hospitals, but those veterinarians are feeding it to the animals. And you still hear that despite the feed directives, because the messaging hasn't really gotten across. I actually had to grade my students and tell them, you need to go read the literature because you're not up to date. They're actually not allowed to do that anymore, by the way. And that's a messaging problem. That's something that we need to do. But the other thing we have to do is not say, well, those doctors can't even, do surgery without infecting it. Because we're both living in the same messy world, and we're both facing these same challenges. So we have to come up with ways where we drop the scalpels and the MALDI-TOF plates, and we talk about what do we have as common problems that we can address together. So I'm going to tell one more quick story. I think I have time if I haven't put you all to sleep yet. So this is another fabulous CDC info, which I really like because it shows the different environments. So the question I'll pose, because I've talked about, where the animal space meets the human space, but I would argue I haven't talked much about the environment overall. So I'm going to tell you one environment story from a really good friend of mine that has done a study looking at households in Kenya and where they get milk from. And yeah, sure, this is Kenya, and hygiene is not perfect. But, go back to the queso fresco story, we're able to make our hygiene not perfect pretty easily too. So just a reminder. So here is a diagram of what happens with food, particularly milk that's fed to young children, and why they get diarrhea. So often they'll just go to a window where they can get sachets of milk. those should be pasteurized. You also could have access to a cow, then you're getting raw milk. Or then there's the ultra-pasteurized milk. You would hope that something's pasteurized or ultra-pasteurized would not be contaminated. This would be the hope. But it's amazing how quickly we're able to contaminate things. The world is messy. So what they did is they looked at multiple points along this pathway and took samples of the environment to see where they had bacterial contamination. Where was it coming in? What's happening here? And this is published. And what they found is that, between when the food is cooling and when they're consuming, whether it's cooked or uncooked, we get a lot of contaminations from just interacting with that food with our hands. Okay. So this just tells you again about the different types of milk, the raw milk, the pasteurized milk, and the ultra-heat treated or ultra-pasteurized. And they gave them the tools. They gave a measuring cup to be able to take it out. So that measuring cup should be clean. It's a new measuring cup every time. And they, talk about how often these are refrigerated. Because they're pasteurized, that usually still is refrigerated, but the ultra heat treated literally is supposed to be made so it doesn't have to have a cold chain. And that seems to be fine. But what we found is that, thankfully, pasteurization and ultra heat treatment does decrease the detection of these different pathogens, Salmonella, Enterobacteriaceae, EHEC, E. coli as a whole, and EIEC or Shigella in these samples. Of course, not surprisingly, raw milk is higher, but in some instances, our packaged fresh milk is right there with it. And then the long shelf life or the ultra heat treated is lower. But it's not nothing. But what they found was that ultra heat treatment or pasteurization does not reduce the prevalence of S. enterica or these other markers through sequencing. So what's happening as that food goes to the kid is it's becoming contaminated. So our lives are messy. We are not keeping it clean. We are not doing a good job of making sure that the kids who need it most, who need this nutrition and need to be clean, are not able to get it without bacterial pathogens. And this is where the real challenge is how do we make sure when we can't stop ourselves from, eating meat that's too raw or, not wanting the yummy queso fresco, how do we message how to better do this to children? Or not do it, as the case is, not infect them. And then we found that the concentration also was not lower. So in those that were contaminated, you would think, what's in there because it started at 0 for the one and already was contaminated for the other. No, most of the contamination is happening after they've opened it, and the amount of contamination didn't matter. And in fact, there's a trend, because you see these guys up here, that with the ultra heat treated, it's almost like we've convinced ourselves that ultra heat treated, it's impossible for things to grow in it, and we're maybe not as clean with that even. So again, it's a messaging problem. Ultra heat treated means that what's in that package, if you draw it out with a needle and syringe, will be without bacterial pathogens. But that doesn't mean that you cannot use good hygiene, right? And I think this is our challenge. So, to bring this back to the first world problem, we need to have better public education about what are sanitary behaviors in our food. It seems like we do this, but it doesn't seem to be getting across. And we can't do it in a way that shames, blames, makes people feel bad, especially, we know most moms who are preparing food or whoever is the caretaker preparing food are already doing enough things. They don't need to feel guilty about what they're making for people. But I think as a whole, we need to have a different perception about what the interaction is between bacteria and food and our bodies. Because bacteria is everywhere. And it's going to be everywhere. And we have to make the distinction of what is harmful bacteria that we have to do things to prevent, and not set up this expectation that we're going to have sterile food or sterile hospitals, because we're not. That's the reality. again, I get to be on the podium, so this is my opinion. I'm perfectly willing to hear other discussion points. But I think that's where we are, and that's what we need to try to convince people of. And then, how do we shift human behavior about these hygiene points as people have less time for food preparation and more often are choosing at the grocery store to get the pre-cut, pre-cooked, pre-packaged food, which is more likely to be contaminated and cause problems. And, the melon and the cookie dough are the two examples on the side, which both did lead to salmonella outbreaks in the last decade or so. No blaming of the chicken, it's just chicken. So, quickly to talk about antibiotic stewardship and hospitals. This is really the same as any place else, but it was really interesting to hear Dr. Flynn talk about the needing to have better understanding of the length of use, because literally in human medicine, this isn't even a choice. They are told, the medical records dictates it to them, and if they try to go against it, they basically have to go call up an ID doc and get it waived. So, it's fascinating to see how the two different rules operate. But the choice of the right antibiotic for the right infection, and the patient, the right amount of antibiotic, and then giving the antibiotic for the right amount of time. And it was that duration discussion that we were having earlier from the FDA. And again, this is another CDC image. Thank you, CDC. So this article came out in 2014, but there have been other ones since, and it's about decision fatigue and MDs. And basically, if you want to convince an MD to do whatever you want, you need to go see them after 3 p.m., because they're much more likely to give you opioids, antibiotics, or whatever you go in there for. Because they're people, and they get tired of telling other people, no, I can't do that, it's not appropriate, that's not what you need this other thing, even though that's what you think you need. And this whole idea of decision fatigue is something that makes a big difference in what happens with antibiotics in hospital settings and in clinics. So what they've done, like I just told you, to try to get around this, is they make the whole scripting very straightforward. You could call it idiot-proof, but of course, MDs are not idiots. But maybe after 3 p.m. And they go through what antibiotics should be used for every type of disease, for kids, for adults, outpatient, inpatient, what is the current hospital prevalence for different pathogens, so what you should be thinking about. And this is the way drugs are scripted. It then has a section that tells you what's available for you to use, what do you have to go talk to the ID docs for, what do you have to be a pulmonologist to give out. And, they go through what is the antibiogram in that hospital for different pathogens with different antibiotics. So this is the type of data that's now in the medical record, in EPIC, for everybody who is scripting to see. And then you can go through for the different types of diseases. So complicated cystitis is one of the more challenging ones because often we don't necessarily want to be giving antibiotics. But sometimes, if they've got an indwelling catheter, maybe you do to prevent, but maybe you don't. And then when you type in that you want to give Augmentin, Clavamox, for something, it's going to tell you, do you really need an antibiotic for this? Are you sure? And then you have to click yes several times. And then if you're trying to use a more powerful antibiotic, you have to go through more efforts. And sometimes you actually do have to get the ID doc. So recommended by an infectious disease consultant. Or you have VRE, or you have another infection. So you already have to have that MALDI-TOF data to be able to script this out. This is how it's being controlled in the stewardship. So would a system like this work in veterinary practice? Would it work for producers in a biologic risk management system? If we think about the hierarchy of controls, we aren't going to remove creation of antimicrobial resistant pathogens, because the pathogens do this naturally. It's things that they come forth with in nature without humans. But then can we have engineering controls where, in the feedlot or in the truck, you actually get these sort of messages to remind you, you really shouldn't be giving that. Can you have work policies or procedures that talk about antimicrobial use? And then, PPE is always least effective. I don't think it's going to do much here, but is there PPE that would then help you at least not carry those pathogens to the next place and prevent spread of those antimicrobial resistant pathogens to another place? Things to think about. So a little dark, I guess literally, not figuratively, but perhaps. So what are the pressures on producers and veterinarians and the role of decision fatigue? So, we always are thinking about the animal health, but we're also thinking about profit to ourselves. We have to live. To the business we're working for. On the producer side, we're worried about land stewardship, protecting the environment, making sure that we have a farm to give to our children. On the veterinary side, we are, by oath, supposed to be protecting the public health. And then we have to make those clients happy. And I think there's a lot of decisions in how this feeds into each other, and there's a lot of fatigue. And it's something we have to think about. So how do we do this better as One Health? Again, I think communication and just knowing that this is a struggle across health with a capital H, and trying not to have this be a blame game, and sharing data and sharing best practices across the systems as much as possible. I think it's shocking. So we've had people come from the hygienic lab to the veterinary diagnostic lab and vice versa, but we're still not sharing data across those two systems within Iowa. And that's something that I think we should do. Heads up, hey, strep zoo is now infecting swine, and it's not supposed to. If it did that jump, could it go to people? Just a heads up. I think it's those sorts of conversations that could happen a lot more. Anytime we're having something jump species. And then, like I said, the NARM system is fantastic, and I think this is something that really should be used more, but I think it's a lot more human data right now than it is animal data, and it would be great to see that become a better balance. So that's all the talking at you I have planned for today. Obviously, except for fabulous Geneva Wilson, and how I helped her with her PhD project, this data came from friends that I've made being at the University of Iowa in the College of Public Health. So the State Hygienic Lab gave me the fun chicken salad story. Maren Schweitzer with the VA, antimicrobial resistance and hospital-acquired infection group, actually connected me to Patrick Kinn, who gave me all the stewardship screenshots so I could talk to you about how they're doing that in hospitals, so that it's something you could think about. And then Kelly Baker she literally gave this at a WASH meeting last week in UNC and last night. So I was asked for my slides last Friday, and I said, I'm not going to get them yet, because I was hoping to get a couple of her slides about Kenya and what's happening with milk and how we have to figure out better ways to try to intervene and keep those kids from getting pathogens in the milk. Questions? Queso fresco. Yeah, Locke.
You can probably hear me without that. Great presentation. I really appreciate it. I learned a lot in the presentation as well, and you sort of challenged us on there needs to be more veterinary data too, and we need to make sure that we're including that information in epidemic outbreaks and so forth. And then in our effort to simplify the message to protect human health, when we do identify point sources, I think sometimes I'm reminded of that quote by Einstein where we should simplify as much as necessary but no more, right? And I think a lot of times producers don't want to end up one panel away from a really bad disease or a fatal consequence on the messaging that goes out to protect people. So a question for you, and maybe one for the whole group, is how do we consider that when we're trying to simplify the message to protect and reach as many people as possible? I think how do we consider that that might look like a more direct connection than it really is. I think there was a lot of subtlety in that outbreak investigation. You know, it's hard to communicate, but is important in terms of not all cows have it or not all types of cheese have it, that sort of thing. And then it kind of gets lost in our efforts to communicate and protect people. So I'm curious about your thoughts or other thoughts on that.
Sure. So I'll take a stab at it, and then I'll open it up to the room for other thoughts and opinions. So the one thing that I'm learning more and more is the information that's available in the MMWR, which I pulled most of that from, is a level of nerdiness that the average person is not going to get 3 miles from. And what's in the published literature could become a threat to a very select group of people. But I think it would be a benefit to many others that are likely to read it. So it's kind of like everything else. It's instead of biological risk management, it's scientific risk management. What's the harm of showing the data versus what's the benefit? And everything comes with risks, and I'm not denying it. But I think if we want to start nowcasting or forecasting outbreaks, we're going to have to share data better, and we're going to have to get it from point sources instead of patients. And that means producers. So I think the other thing, and that's why we're all here, we have to be prepared to do, is if it does get into the wrong hands and negative messaging starts happening about something that's really not appropriate, in fact, it was, this is control data of stuff that wasn't related, we have to have immediate, thoughtful, energized responses to explain why those things do not connect. And we have to be prepared for that, which means that we can't just stay in our little ivory tower and be like, oh, look at that. Sucks to be them. And, I think some of us are up to that challenge. I think some of us are here and would love to be up to that challenge. But again, if we don't do it, if we let science be forgotten or dictated by people who are not putting it forth, that's more of a risk to us. Other thoughts? Again, it's my soapbox and I'll get off of it.
Hi. So Don Sievert from the CDC. Thank you for that. And I'm glad that you used Salmonella Newport as the example. One comment that leads into that. All of the whole genome sequencing testing that we do at CDC does require culture. And so it still requires growing up the isolate and getting that. So there's a little bit of time. But you are absolutely correct in that we have a whole bunch of new data that we've never seen before. And we've moved now into that realm, like you said. We're there with the enterics that we follow at CDC. Healthcare-associated infections for specific bugs are on their way to doing that, and state health departments are coming up to speed. So it does become a communication problem for CDC. And Salmonella Newport is the perfect example. When you showed it, my colleague looked at me across the room because that wasn't easy to deal with as far as what decisions were going to be made and when information gets put out. So when it is an outbreak, it's very easy. You're working on an outbreak, everyone's working together. USC and FDA are always involved in the groups in the state that are involved, or the corporation or something, to say, we have a point source. You're right. Those are cleaner, easier. Everyone's used to those, really. But I think for this group, it's a good question, and it's good feedback to CDC that they wanted to put it out because they wanted people to know there was this new thing from all the sequence data that they had, and they were seeing it, and it was serious, like you said, because now these are 2 drugs that if these patients are getting it, they may have treatment failure. But it was early, and they didn't have answers. And that then is hard for people to read and say, but what? We're not telling us what to do except cook your meat and don't eat raw cheese, which we say don't eat raw cheese all the time because of listeria. Right. So that is, and that's the new norm that we've had multiple conversations at C2C about how to deal with. When do we put information out and how do we put it out? Now, maybe it's you don't put it out in that format and you have more conversations with the producers and the processing plant in the area and that kind of thing. But then it's always going to be, when do you say it? Because every time we do something like that, we have consumers then that push back and say, but you didn't tell us. You didn't tell us to cook our meat and not eat raw cheese. So it's a huge balance, but I think it's really important. And I think this group is a perfect group to give that kind of feedback to CDC so that we can figure out how to share the information and when to share the information. Because you're right, it's all new. We know way earlier and we know way more, but you don't want to say the sky is falling every time, and you don't want to be, running around worrying about every single gene that you find. But you also don't want to be, you didn't tell us, and if you had told us sooner, we could have stopped it. Or if we had found it and we knew it was on the farm, we could have stopped it then, and it wouldn't be through, Salmonella infantis is a conversation that's had about how widespread Salmonella infantis is in poultry. And so when did we see it? When should something have been said? Who knew what when? And when finally did that conversation get had, and how much earlier should it have? So CDC needs a lot of input on that because it's not easy to do the communication, and we want to do it as best as possible and get it all out there, but it could be overload and burnout too, and then that's a scary thing too, because then nothing's important anymore. You're talking about it all the time. I mean, the news media tells us that sometimes. We don't want to hear about every outbreak you have. There's an outbreak every day. Just send people to the website. So when is it important and when is it not?
Absolutely. Yeah. Thanks for that, Dr. Sievert. So that's actually one of the questions that's come through Slido is we need to understand what news is and what needs to get out. So when it's with Salmonella, it's news, and, it isn't news if it doesn't have an infection. But what I'm saying is that we need to have surveillance telling us overall chicken salad doesn't have Salmonella, right? And that's the other thing to remember. So that doesn't mean it has to be news, of course. No. But, well, unless they really wanted to prove that you can go eat chicken salad. But I think we do need to keep doing the sampling of environments. Will bacteria eventually overcome hand washing? Well, much like spraying bleach onto the curtains lasted for a bit and then went away. Hand washing decreases the burden. It decreases the likelihood that we're going to pass on that infection. But are there times when, most of us vets can think of things that we have stuck our hands into that have become so contaminated that hand washing that first time probably didn't make a difference? Yeah, you can have still very high pathogen burdens on your hands despite hand washing. Does Molly-Tough differentiate between live and dead? No, unless you've cultured first. And a lot of places still are culturing first, and then it had to be live to be able to be detected. But like I said, some hospitals are going right from patient sample to MALDI for time. But then they are potentially picking up things that are dead. I can fight with the microbiologist in the room about this. I think the likelihood that you're getting dead bacteria and a CSF, even dead bacteria shouldn't be there. So, and if they're dead, they probably were live at some point to get there. So I care either way. Anybody gonna fight me on that? At least not right now? Okay. Great questions. Other questions? Other conversations? Yes, we got some.
Question. So on your chicken salad example, you did your investigation and found all the ingredients to be clean. And I'll point this at CDC as well. Do you ever go back to the people preparing the chicken salad as a source of the infection? Again, a concern I have is there are several reports in the literature where resistant salmonella were brought in by workers out in California who tended to use the silo or the silage bunker as a outhouse, gave the salmonella to the cattle who did what they do, clonally spread it, and that was the source of the infection. So do you ever go to the extent of looking at the people handling the food as a potential source and not the ingredients?
Yeah, so I'll I'll take the example I gave and give the explanation, and then I'll let others talk about what was done more broadly. But for this example, they cultured people, they cultured the environment, and what they found was they had made a big lot of chicken salad in a big white pail that they had not cleaned sufficiently. And that's where the salmonella was. So that then got spread across multiple sources. I think they actually put the raw chicken into said bucket, and that led to chicken salad with salmonella across many, many lots of chicken salad. And then they went back and trained them, like, why that makes no sense and what we can do gently and kindly, why that makes no sense, and what going forward is the better way to do this. Whoever wants to take the other side. Dr. Siebert.
So, and FDA and USDA are here as well. When there's an outbreak, we all have to work together. And CDC is not regulatory, and different parts, of USDA are and are not. So I think the main message to people is that we all would love to be able to get as much information as we ever possibly can during an outbreak situation and trying to figure out source attribution. And so everyone who's willing to let that trace back and tracking happen, we would appreciate it. But you know that we hit walls. We don't have enough information from animals on the farm. And I know that it's confidentiality, it's security, it's risk, and it's scary. But if the more people are willing to work with us, many times it would be, thank you for letting us. It's not that. It's not you. We have to look somewhere else. But without the negatives, we can't identify where the source is. And so there's all sorts of that going on from all angles whenever everybody's working together on an outbreak situation. But if we do figure out the best way to do it in the communication, and it's not a bad, scary, negative thing, it's yay, chicken salad company for pulling it off the shelf, then everything becomes a positive because there are bugs everywhere. And you're right, there's no sterile environment. We don't live in one. So it's not about the bad, how did it happen? It's, ooh, look how fast we identified it and pulled it and fixed it so that it won't happen again. And that eliminates and decreases the amount of people getting sick. So,
do you want to do me a favor and cover the bottom one? I could do it too. But.
Oh, it might be helpful to explain the difference between investigation, multi-state outbreak, and single state, and explain CDC's roles compared to FDA and USDA. Megan, do you want to do it?
Thanks, Megan.
Absolutely. Hey, everyone. Ooh, I'm Megan Nichols, and I work on the Outbreak Response and Prevention branch at CDC, and we do the multi-state Salmonella, E. coli, Campylobacter, and other bug investigations. And so I can speak to this a little bit, is what we do at CDC is a lot of coordination of the multi-state outbreaks, because at the state level, you all have health departments and ag departments and others that are extremely well trained. They know the ag extension officers, they know the food production companies, and they're handling a lot of that at the local level. When we start to see a person in California and 10 people in New York and 5 in Iowa and maybe a couple in Michigan and maybe 2 in Canada, and they all have that exact same genetic strain of salmonella, that's when we really start to ask some questions about, could there potentially be a common exposure across all those people? And that's where we get involved to gather the information, the laboratory data from all of those states and sometimes other countries, and the epi information. We got to make sure those questions are asked of the same people in the exact same way so that they are comparable. And once we find that, then we're doing some statistical comparisons to say, all these people ate chicken salad, for example. Did they eat the exact same chicken salad? Can we get the ingredient list from the restaurants to actually compare and see if it was the exact same company that produced the mayo or produced the chicken? And then not only do we have to have the lab piece and the epi piece has to match up, we got to make sure that people are actually eating this product at a greater rate than what we healthy people eat. So are the sick people who eat this product more likely to actually get sick from eating it versus those of us who eat chicken and don't get sick. And then lastly, we work with USDA and FDA throughout this process. We're constantly reviewing the data, showing them the evidence, talking to them about what this could be. And they potentially are the ones who are going out to talk to the food manufacturers and the plants to actually say, is what we're seeing in the human side actually what we're also seeing in the food production environment? So if you had to guess, you've heard today about a couple outbreaks, and this is probably a handful, maybe 10, 20 were announced in the news over the past year. We have about over 250 that we monitor across the year. So the vast majority of outbreaks you don't hear about, and the vast majority of investigations that are actually going on, whether it's talking to a guinea pig producer about the pets that end up in the store, talking to a company that produces some pig ears, or talking to a lettuce conglomerate, those conversations, those investigations are actually going on behind the scenes every day, but they don't necessarily make it to the point where there's something actionable that we can communicate on.
Thanks a lot, Megan. Absolutely, we're going to have to redefine outbreak with this new MLST data, and we're in the learning phase right now. I'm, again, speaking for my colleagues, but so I think that's what I was saying about the data is right now we don't exactly know what our data means because we're detecting things in a new way, and you can't say that it's going up because it's a different detection. So it's what's going to happen going forward that's going to be informative, and we're going to have to reset what are levels that are normal for our messy lives, and what is an outbreak. And then lastly, I love the top question because I live in the viral parasite other worlds, and there is certainly drugs that don't work. Viruses are fantastic at overcoming antivirals very rapidly, and we're actually starting to have some problems with some of our anti-parasitic drugs stopping working, like ones that have earned Nobel Prizes. Ivermectin is starting to not work in some locations for certain livestock. And some of the drugs for heartworm in dogs aren't working as well. So I think we already talked about the complexity and the problems. So one side of me says, yes, let's bring all of the microbes in, parasites, viruses, and bacteria. But that would be a 7-day conference instead of a 3-day conference. So, these are broadly important topics across all pathogens.
Great. We have time for maybe one or two, or we're done with questions. We'll got one in the back there.
Yeah, so Sarah, Center for Science and the Public Interest, Sarah Sorsher. One of the things that some of these new outbreaks has brought to light is just that, producers certainly have a strong incentive to try to go and control some of these outbreak strains because they don't want to run the risk of having to do a recall if someone gets sick and it's tied back to their products. But generally, they don't really have that information until CDC declares that there's an outbreak publicly, because the information from case patients is uploaded on like a 6-month delay. You can tell me better. And I'm wondering if CDC is rethinking that and trying to figure out ways that they can provide that information in a more timely way before necessarily they're going to do an outbreak alert, so that just producers can be more aware and be more proactive about controlling new strains as they emerge.
So as I've done, I will give Christy's thoughts and then put it out to the people who actually know the answer. For influenza, for instance, they are trying to put that data out as rapidly as possible. Usually it's still on a couple-week lag. So you're not yet, that's why I talked about nowcasting, which is the ability to predict what's happening today, which we don't have the data out yet for, versus forecasting, which is what's happening in the future. The hope is that with more streamlined reporting, the challenge that the CDC has is that surveillance is done at the local and state, and then it has to feed into the CDC, and then they can put out the data. There are states who have great surveillance data, and it goes up faster, but you have to then look state by state, and then it's the compiling of the data. So I think the future could happen with faster data, absolutely. Then it's the question of There are probable cases and confirmed cases, and case definitions, depending on what's happening and where it's happening, might be slightly different. So for instance, the Lyme data for 2016 isn't available on the CDC maps because Massachusetts decided to define their cases differently. Love epidemiologists. I'm one. We're very strict about our case definitions, and when they don't match, we aren't allowed to call that data the same. So what that means is that you don't have any data because we are going to fight about the case definition. So it's those sorts of things. Maybe we can get over ourselves and decide, okay, that's a slightly different case definition, but we'll still give you the data, but we'll put it with a different color and a big asterisk. It's all about quality versus speed, and such.
So just a comment about that. Our isolates that we have from CDC are actually available very, very close to real time, especially with whole genome sequencing. They're publicly available on the NCBI website. So no longer do we have quite the delay. It's actually quite timely. And what I will say is, in terms of outbreak detection, that does take some time because we're getting the lab, the epi, and the trace back. But what I would say is, actually, if you wanted to go in and try and find things before the outbreak starts, trying to start and actually see if there's some human matches to maybe, one person that seems to match a product or two people that seem to match a product before the outbreak actually happens, that's actually much more valuable. So for any producers that are doing testing, and I know a lot of our food industry colleagues are doing this, they're actually looking at the DNA sequence of Salmonella, Listeria, and E. coli that might come out of some of their environmental testing and comparing that to what we're seeing on the human side in NCBI. So that data is up and it's publicly available. And I know FDA and USDA FSIS also upload isolates to NCBI. So that data is there. And if anybody's interested, I'm happy to touch base with you and get you the website.
Thanks, Megan. Okay.
Great. Let's give Dr. Petersen a hand.